Yeah, and I'm Herman, so it's okay.
Well, thank you very much. I'm Ken Rasky, and joining me is David Rich, our Executive Vice President of the Greater New York Hospital Association. And first, let me say to Madam Chairman and Mr. Chairman that I want to thank publicly the workers who toiled over the last 48 hours down in the downstate area on a horrendous snowstorm, and the dedication of the hardworking staff, nursing staff, allied professionals, physicians, to make sure that the patients were accommodated and taken care of in the best possible fashion. So my heartfelt thanks to all of them. Much appreciated by everybody in the healthcare community. Now, with respect to the subject matter at hand of this hearing, I want to hit 5 subjects in plain talk, and they are the capital issue as it relates to distressed hospitals, Health Republic, the minimum wage, straightforward, Med-Mal, and the nurse staffing. Let me begin by dealing with the troubled institutions. Yes, you have 28 of these institutions are listed here. You all know who they are. Some may or may not be in your various districts, but you certainly have colleagues that represent them. And the fact of the matter is, if you take a look at what's going on currently, there is no good way out. On the one hand, you can continue with your subsidies and life support. Up to $400 million now, could be increasing substantially in the future. Or you can let them fail. So what happens when you let them fail? Well, you know what happens then. Your communities go up in arms, justifiably so. Local elected officials, state officials, federal officials, everybody gets involved, and you have basically chaos. So there's your 2 choices. Pick one. Well, maybe you have a third one. And that third one is a proposal which we had made to the executive branch throughout the fall, and that is to create an incentive program for healthcare systems, large ones, you all know who they are, to adopt and adapt these facilities to the new world. It doesn't mean to cross-subsidize them. It means to adopt and adapt to the new environment, to make sure that their communities are served properly. And when I made this presentation to the executive, I said, I think that $500 million will be necessary to do that for 1 year, but you're going to need a 5-year commitment. That's $2.5 billion over the string of years. This way, and if you think about it, it's only like a short-term investment, even though 5 years might seem like a long time. But on the track that you're on right now, you're never going to get out of it unless you take one of those 2 possibilities: continued subsidization or failure. So this way you can eventually wean yourself of the subsidy, not have the chaos at the local level, and have a healthcare system that best serves New Yorkers. So that's our idea. I want to thank the governor for putting in the budget a placeholder of $195 million, and I would like the legislature to add to that, to make it a more robust sum, and then, more importantly, the future commitment to do it year in and year out until we have satisfied the needs of these various communities. So that's our idea on capital. Health Republic, again, plain talk. Health Republic, you heard, is about $190 million into the hospitals. I don't know exactly how much it is into the physicians and home health care agencies, but it's obviously a significant amount of money. We have proposed, and this is something that has been proposed before, that we have a guarantee fund where an assessment is placed on the remaining insurance companies. So what do we get when we say something like that? Well, we get the insurance companies coming back and say, well, hell no, we won't do that. And I say to them, that's baloney. That is nothing more than crocodile tears on this particular subject. So let me explain to you why. In 49 other jurisdictions across the United States, you have guarantee funds for health insurance. Guess who doesn't have one? Well, that's why we're here today. And why not? I don't know. I can't explain it, but we need it. You have it for property and casualty companies in New York, but you don't have it for health insurers. So when the insurers say to me, well, this is going to be a tax, I say to you, most of these insurers in New York now are national companies, aren't they? Aren't they? Aetna, United, the list goes on. And what do these companies do? They didn't complain in New Jersey. They didn't complain in Pennsylvania, California, or Illinois. They're complaining here. Now, I submit they are not credible on that particular subject. So take stock of what is important for New York as we frame a solution to help the public. Minimum wage. Senator, you asked the question. Here's where I'm coming from on the minimum wage. I believe it's a moral mandate. I really believe that. I know how hard it is to make a living. I understand that. You pay $9, $10, $11, $12 an hour to somebody that is in home health care, nursing homes, what have you, across the state. It's hard. And we ask a lot of them. I also have an obligation to my health care partner, $11.99 SEIU. This issue is important to them, so therefore is important to me. Now, the problem with it clearly is, well, how do you finance it? That's number one. And then once you solve that particular problem, then you have to clearly exclude it from the calculation of the cap. Otherwise, it becomes a screwy calculation. You give on the one hand, then you take it back through the cap, so it doesn't make any sense. So the logic there seems pretty clear, right? On Med-Mal, we have the highest Med-Mal costs in the United States. Ladies and gentlemen, I submit we do not have the worst doctors and hospitals in the United States. Wouldn't you think we would if we have the highest cost? Well, we don't. By most metrics, we have the finest hospitals and the finest doctors in the United States. So what's wrong? Maybe we have the worst tort laws in the United States. That, I submit, is the issue. We need to change it. And we need to change it this year because the erosion factor is astronomical. Finally, with your indulgence, nurse staffing is an important issue to the Greater New York Hospital Association. We know that legislation has gone through an Assembly Health Committee already and is slated for future consideration with the Assembly. I assume that that future consideration will also be made in the Senate. It's an important issue to me. Nurses are the backbone of the healthcare system, but I also submit that staffing ratios do not work. And they simply do not work because in each individual institution, you have a different configuration of services. And in addition to the point that was made earlier by a number of you, the healthcare system is evolving into an ambulatory component. More and more material medical care is being given on an ambulatory basis. So as a result, the idea of fixed ratios doesn't work. What does work? Local consideration. This past year, we've had a number of major academic health centers in New York have negotiations with NYSNA, the New York State Nurses Association. They came to a successful conclusion. They were not only about wages and benefits, they were, in point of fact, about staffing. And these decisions should be made on a case-by-case, local determination basis. And that's where we come from on this matter. In conclusion, it's been my privilege to be the president of the Greater New York Hospital Association for a long time. I'm dedicated to the health care of and well-being of the people of this state. And I believe, and I firmly believe, that the New York State Legislature, as a body, has been a major reason why the great successes have been made in healthcare in the state over the years. You've done a marvelous job. Doesn't mean that we agree, but you've done a terrific job, and we don't take that job lightly. So, ladies and gentlemen, I want to thank you on behalf of my people, the healthcare providers of New York State and New York City. Thank you.
Thank you very much, Ken.
Thank you very much, President Rasky. I don't think that because of your comprehensiveness, there are any questions. So thank you for your testimony today.
I'm sorry.
No. Be proud.
You close clean. Ken. Just one question. No, they don't. You just stand there.
I'm sorry. Forgive me.
No, I just want to know who's here longer, you or me?
I beg your pardon?
Which one of us is here longer, you or me?
I think...
No.
No? Well,
I came here,
we
you
both
would
should
know.
get a reward for that. Thank you.
Just checking. Thanks, Ken. Laura Hyde, Vice President, Public Policy, New York State Association of Healthcare Providers.
Good afternoon. How are you today?
I was good when I started.
I'm joined today by Beta Reynolds, a current board member and past chair of HCP, and she's the Executive Vice President for Caregivers, which provides home care services throughout upstate New York. HCP is a trade association representing approximately 350 offices of licensed home care service agencies, certified home health agencies, long-term home health care programs, and health-related organizations throughout New York State. On behalf of the HCP Board of Directors and members, thank you for the opportunity to testify today. I'm going to summarize from my written comments in order to stay on top of the time. We all recognize the importance of home care. Home and community-based care is seen as a central component for new models of healthcare delivery aimed at achieving the state's triple aims of improving care, improving health, and reducing costs within the Medicaid system. Home care is the patient-preferred option, enabling disabled, chronically ill, and elderly New Yorkers to remain with their families and be cared for with dignity in the comforts of their own homes. As a growing percentage of New Yorkers age in place in their homes and communities, long-term home care will become increasingly important to support those with chronic conditions and functional limitations. Despite the widespread recognition that home care saves money by keeping New Yorkers out of more costly health care settings, the governor's proposed 2016-17 budget continues a years-long pattern of disinvestment in home care. Not only does this budget fail to alleviate the very real financial pressures home care providers across the state are currently experiencing, it includes a significant minimum wage increase with no funding to support it. Since home care agencies will likely be the most impacted by the governor's proposed budget, I'd like to begin by explaining the unique position of licensed home care service agencies. The acronym is LHCSAs. LHCSAs make up the majority of HCP's membership. LHCSAs employ the vast majority of home care aides in New York. However, although most of the services LHCSAs provide are funded through Medicaid, LHCSAs cannot be directly reimbursed from Medicaid. This has important implications. It means that LHCSAs are not eligible for funding from the various MRT programs intended to assist providers during this transformation, including support for distressed safety net providers. Home care is facing a perfect storm of challenges, and this is before the minimum wage increase. Mandatory wage and benefit costs for home care agencies in New York have dramatically increased over the past 3 years, while reimbursement for these services is woefully inadequate. It was alarming to hear Commissioner Zucker and Medicaid Director Helgerson testify earlier today that the 2011 home care worker wage parity law would be a model for the state to follow when phasing in the proposed minimum wage increase. Wage parity rates are now $14.09 in New York City. This is $10 in base pay plus $4.09 in supplemental wages and or benefits. And they'll be going up to $13.22 in Nassau, Suffolk, and Westchester counties in March, a $1.72 increase over the previous year. While the law was well-intentioned, the promised increases in reimbursement have not materialized. To date, only $35 million in QI VAT funds have been distributed to home care agencies, and eligibility has been severely limited. Even for those providers that ultimately receive QI VAT awards, the funds will not come close to covering the additional cost of compliance with the wage parity law. No such assistance has been offered to agencies in Westchester, Nassau, and Suffolk, which also have to comply with the wage parity law. Moving forward, particularly as the state transitions into Medicaid managed care, it is imperative that home care providers be fully compensated for the cost of complying with state and federal wage and benefit mandates, and that this funding comes through in advance and not years later. We're dealing with statewide minimum wage increases, mandatory health insurance coverage under the ACA, double-digit increases in workers' comp rates, new federal overtime payment requirements, all within a very complicated transition into managed care, which has been fraught with problems, which I have addressed in our written testimony, but will not go into any further now. Critical funding promised from the state to reimburse or at least partially offset home care costs have yet to be seen by home care providers. Most recently, as an example, the Federal Fair Labor Standard Act rule was revised to require higher overtime payment, and that went into effect October 13th. Home care agencies have still not seen the emergency funds promised by the state to reimburse them for the additional cost of compliance. This has had an impact. We've come here before many years saying that continued cuts are going to have an impact in the care that we provide. And as an example of just how vulnerable this industry is to wage increases, I'm going to go into a little bit more detail on the FLSA. In addition, there's funding that's provided through the budget that we're not sure if it gets down to providers. We want to make sure that there's more transparency and that providers actually do get the funds that are sent to managed care that are intended to help us with workforce recruitment and retention. Home care agencies in New York employ over 200,000 home health and personal care aides who provide more than 300 million hours of care a year to New York's frailest citizens. Our workforce is our major investment, and thus we are especially sensitive to changes in labor requirements. Because we're mostly government funded, we can't simply raise our rates when the costs go up. So going back to the federal overtime increase, it was a relatively modest increase compared to what we're looking at with the minimum wage increase. It changed the way overtime is compensated from time and a half of minimum wage to time and a half of the base pay. And yet, without the funding, the home care industry that's already in crisis simply could not absorb these additional costs and have been forced to take measures to reduce their overtime hours that in some cases they know are not in the best interests of either their clients or their workers. Agencies have had to limit their home care workers' hours, assign multiple aides to cases. Many are not accepting any new live-in cases. And in areas where there are staffing shortages, some agencies have been unable to guarantee that they can meet clients' requests. The impact of the minimum wage increase will be especially significant for New York's home care industry, where more than 90% of the workforce earns less than $15 an hour. HCP, together with Haney's, excuse me, and other agencies have worked together on these estimates, and at a minimum, these will cost at $15 an hour, $1.7 billion more annually once phased in for the home care industry alone. And this doesn't even anticipate expected increases in home care utilization. There will be immediate and significant Medicaid cost implications in this coming fiscal year, particularly in New York City, where most of our hours are served and where average wages are below $12 an hour for home care workers. Most of these hours are Medicaid funded. So we're working on that estimate on year one impacts, but you can be sure that they will be significant for the home care industry, including the compression factor, which will kick in even at that first year level. I'm running out of time, so I just want to make sure that Bader has an opportunity to speak. I just want to bring to your attention that while we're talking about the Health Republic collapse, the HHH Choices Health Plan and MLTC in Westchester also filed for bankruptcy this year, leaving home care providers with more than $13.7 million in outstanding claims, and this has to be taken up by this legislature because there are going to be more collapses in the future. We must make sure that providers are made whole in these circumstances. The home care industry needs additional resources to help us through these healthcare transitions, in particular with healthcare IT. And in conclusion, while this proposal includes grand and ambitious proposals to invest in vital infrastructure for New York, like our roads and bridges, the home care industry also needs infrastructure investment. If home and community-based care is to be the bridge to the future of New York's healthcare delivery system, we need to invest in it today. Thank you, and I'll turn this over to Bader.
Thank you, distinguished members. I represent the geographic areas of Western New York, Finger Lakes, Central New York, the North Country, and Mohawk Valley region. We are a multi-site licensed home health care agency, and we provide services to well over 1,000 clients in these communities, employ upwards of 700 field and in-office staff. I wanted to speak to the minimum wage issue. You have heard a great support of the issues pertaining to that, but I do want to mention that much of our work, although may not be totally Medicaid-driven, the Medicaid rate, the process of calculating a Medicaid rate, which precludes having any cost of living and a cap on labor and other types of adjustments to date, actually is the model for other negotiated rates with health insurance plans. Sets a base for what our private pay rates must be. So regardless of our mix and our models, everything is driven by this Medicaid rate, and we do obviously need to address those concerns in order for us to be able to address minimum wage concerns and other cost-related factors. And I just want to mention that we have other incentives and other types of costs pertaining to travel and other pay that will be impacted through this compression point that has been spoken about. Everything that we provide for our staff, including the consideration of merit raises going forward, may become obsolete if agencies are not able to manage the base wage that is out there. Thank you for the opportunity. Wow. To the second.
Questions?
Senator Hannan.
You mentioned the... You mentioned the figure of 1.9 billion?
1.7, correct.
1.7. That's a cost to home health care agencies
Additional cost.
because of the federal overtime rule?
No, because that would be the additional cost of the proposed minimum wage increase if it went up to $15 an hour today.
And over what period of time?
That would be at the $15 point. So that would be if today the rate was $15 an hour. That's what the additional cost would be.
Okay.
We estimate it would be higher, obviously, once we factor in, the expected increase in usage of home care services.
And what is the cost on an annual basis of the federal overtime rule?
The Department of Health is working on a rate-setting process now. They haven't identified that yet. They're going to be putting out a survey. Mercer's going to be doing a survey to get a better sense from home care providers as to what that cost is.
Okay. Thank you.
But I will say that obviously, we're talking about a difference between a significantly higher impact from the minimum wage proposal.
Well, in the meantime, is it possible that home health care agencies are going to move people into nursing homes because if they've had it 24-hour care without having to pay overtime after 13 hours, but now they have to pay full 24 hours, they're going to move them into nursing homes?
Well, so far, we're still not paying at 24 hours, unless it's a 24-hour case. Most live-in cases are paid at less than that, 13 hours, provided they have a certain amount of sleep and breaks during the day for meals and so forth. But even so, we can't really answer that question as to how many people might be moving into nursing homes at this stage.
Thank you.
Senator Savino.
Thank you. I don't have to ask you about your position on the minimum wage. We had that conversation in the hallway before, and I share your concerns about it. I'm just confused on the overtime issue. So prior to this federal ruling, home care workers were not entitled to collect overtime after 40 hours a week?
They were, we actually rely heavily, our industry in the past has relied very heavily on overtime hours. So there's been a pretty major restructuring that's happened in the past year just to deal with this very small increase. When you think about the number of hours we supply, over 300 million hours a year, and the very narrow margin, and many of our agencies are underwater right now in terms of our reimbursements, a very narrow margin that we operate under. Our agencies, saw what was coming. They saw that the government had not adjusted rates, that the plans were not going to be increasing their rates, and they knew that they had to make these adjustments to be able to stay in business and maintain their weekly payroll obligations. So whereas we might have had in the past one worker doing 60 hours, a week for one one client, we'd have to break that up now to 2 or 3 workers. Now, in some cases, that's fine. You can achieve efficiencies, but in some cases, that's detrimental, particularly for patients, for instance, who have Alzheimer's or dementias, who have particularly, challenging situations where change can be very disruptive and traumatic. Mm-hmm. So that's when we can answer about how the impacts ultimately have gone in terms of where some families have had to make difficult choices. But for many of our agencies, we've had to change our staffing. 80% of our agencies surveyed reported that they are not taking any new live-in cases. And where are these people going? I don't know the answers to those questions. But I actually had in my, hyperventilating, trying to get through too many words in too little time, somehow admitted from my testimony the important point that we do support our workers. We realize that they are the heart and soul of the care that we provide, that they're dedicated, they work hard, it's difficult work, it's challenging conditions. We totally support the need to provide fair wages for our workers. The challenge is, we have to pay them in real money, and that isn't coming.
Oh, we totally agree on that. And you didn't mention it in your testimony, but it is in the written testimony about the high cost of workers' compensation cases and the rate of workers' compensation injuries that are occurring in the home care industry. Can you explain, how is that happening? What's happening there that's not happening maybe in hospitals or what can we do to address that?
I'm very glad that we have Bader here because she's actually done some tremendous things within her agency to reduce workplace injuries. But you have to realize that it's not a controlled setting. It's not like a hospital, nursing home. People are going to homes, they're tripping over things, there's dogs, there's any number of, you name it. I'm sure Bader can tell us a story about that. The workers' comp rates increased by 35 to 40% 2 years ago and another 25 to 30% just this year. So our workers' comp rates are among the highest of any industry. And again, that sort of falls into this whole category of unreimbursed expenses, which we definitely need to have. It is part of that is the high rate of injury. You're talking about lifting people who are heavy. And why doesn't Bader answer that question more?
Well, it is not a controlled environment, as Laura said. So we are not able to insist on some of the things that we can have in an infrastructure in a facility. While we do evaluate for safety and we do try to encourage and not put our employees in harm's way, there are circumstances that we sometimes can't control for in a home setting. And it is the client's right to refuse or request certain things be done. And then we have to make determinations as to whether or not we can safely provide that home care services in their home. Or maybe they do need to go to a higher level of care or a different setting that could be more costly.
Mm-hmm. Thank you.
Thank you.
Thank you very much.
Thank you.
Medical Society, State of New York. Joseph McDonnell, MD, President. Elizabeth Dares, Chief Legislative Counsel.
Good afternoon, Chairwoman, Chairman. It's a pleasure to be here. Regrettably, Dr. Maldonado cannot join us today. And on his behalf, and on behalf of the solo, small group, large group, and employed physicians across New York, I thank you for the opportunity to present our reaction to the budget. Regrettably, today, I must express great concern with regard to a number of the provisions included in the proposed budget that exacerbate the already challenging practice environment that physicians face. Physicians, while endeavoring to transform their practices, confront certain market forces threatening their very viability and contend with increasing costs associated with many of the federal and state mandates. The costs of running a practice continue to rise steadily, while Medicare and commercial payers continuously reduce our reimbursement. Exacerbating the situation for many physicians is the significant financial losses that they have incurred as a result of the demise of Health Republic. While we have a number of newly insured and have seen an increase in Medicaid beneficiaries, coverage being offered is less robust, with many plans narrowing their networks, who are dropping scores of physicians who have historically served this population, thereby impeding access to care. So with regard to the budget, As Senator Seward mentioned, and many others have discussed already, the budget fails to include a guarantee fund or other pool of monies to assure that physicians and other providers can be reimbursed for the services that they did provide to the enrollees of Health Republic throughout its demise this fall. In Westchester County, for instance, we have 5 physician practices who have lost more than $12 million. And while we're getting more information on the aggregate nut that physicians are bearing in terms of arrears, I think we can safely say and guesstimate that it's around the $100 million level. We urge, consequently, that the legislature work with the governor to identify a funding source to make physicians and other providers who served this population whole. The budget also includes, would cut an appropriation for the excess medical liability program by $25 million. As a result of this cut, currently there are 23,000 roughly physicians who are covered under the excess program. They receive an additional layer of $1 million in coverage over and above their primary layer of coverage. 55% of physicians would be dropped from the excess program if this cut were to be implemented. Physicians who are neither neurologists, general surgeons, or OBGYNs. So everyone else, north and west of Greene County, will be dropped from this program. That's every cardiologist, including cardiologists in Olean, New York, anesthesiologists in Syracuse, New York, and every primary care physician in the North Country will be dropped. In Kings and Queens County, all primary care physicians will be dropped, as will all ophthalmologists and anesthesiologists. You have an interesting circumstance in the first territory, which includes New York County, Westchester, Sullivan, Orange, and Rockland counties. There, you have 2,108 internists, but there's only funding for 527. How exactly will that funding and coverage be allocated amongst those internists in Territory 1? How will physicians continue, these physicians who will be dropped by this initiative, be protected? We have to recall that it was first implemented in the mid-'80s because judgments and settlements pierced the primary layers of coverage afforded and purchased by physicians. Nothing has changed. In fact, the situation has been exacerbated over the years. If anything, proposals that are currently being discussed in the legislature that would increase our liability exposure are going to further exacerbate this problem. If we are going to continue to attract the best and the brightest to the state of New York, as the Commissioner says he wants to do, we need to restore funding for the excess program. We're also concerned by a proposal that would allow retail clinics to be established in New York without CON review for public need. This proposal specifically will allow publicly traded for-profit entities to directly own healthcare clinics in communities that are already saturated with healthcare providers. Under this proposal, it's not necessarily limited to establishing these clinics in underserved communities. We're also concerned by sweeping changes to New York's workers' comp program that will discourage physicians from participating in the program in the future. And lastly, I would like to also encourage action to reduce medical liability premium burdens shouldered by physicians in New York State. We're among the highest in the country, and as Mr. Rasky noted, medical liability payments far and away exceed every other state in the nation by more than twice the second highest state. We need comprehensive reform to reduce these costs, and we encourage you to reject measures that on their own would expand the cost burden associated with medical liability for our physicians. Thank you very much for your time.
Thank you. Questions?
Thank you very much.
Thank you. New York State Health Facilities Association, Deanna Stephenson. Did I pronounce that correctly? Probably not.